Thank you, Ursula, and welcome everybody. It's lovely to see so many people here today, and welcome to Marcello. I'm really looking forward to our conversation today. We met before the event, and I think it's a topic that we could go on and talk about forever. There is so much that can be done in this particular area, and I'm particularly keen to explore how the work that the Open Data Institute does can support the social prescribing agenda. I guess one place to start is the pandemic. I mean, we have seen significant portions of society, whether they're the young or the old or everybody in between, impacted in some way with the pandemic over time. We did a story last year, we released last November, looking at the lives of children in the pandemic and how they've been impacted. And we had a really good engagement with Bernardo's. And what we saw was that once the schools closed, the referral of children to access support absolutely just completely fell off because those children were being sort of captured by school and they were being referred on for the support that they needed. And then once the schools reopened, there was a sharp increase to the extent that it is beyond even what the schools are able to cope with now. And that's just our young people. And, you know, they are the future generation for the country. And there's a lot of support that's needed there as well. We also have the recent flagship story that we launched in November, which was actually looking at a study. It wasn't a particularly deep study, but it was a study into how could social prescribing actually relieve some of the pressure that the NHS is currently under and free up GP appointments by using some sort of a social prescription intervention as well. So there's so much to go at here, and I think there's a real opportunity to actually explore this really well. The problem I think we're going to have, Marcello, is staying within our time. But anyway, we will try and make sure that we've got enough time for questions at the end. So I guess, you know, you've got a huge amount of experience in this area, so I'm really excited that you're here today. And the practical application of social prescribing is so disjointed and different across the UK. Do you want to tell us a little bit about, you know, how you understand it?
Yeah. First, before I start, I need to make a correction because I'm from the University of East London, because otherwise I might get sacked, you know. You never know, it goes on television. So, so anyway, so in terms of social prescribing, yes, as Louise said, I mean, the picture is very mixed across the UK. I mean, and one can think of social prescribing as just connecting an individual to the voluntary sector for various activities. It might be yoga, it might be mental, you know, arts, it might be other things, or even a walking group, for example. And so just about connecting an individual. But more and more so that would be one side of the spectrum, if you like. The other side of the spectrum would be what is actually promoted by the NHS, which is basically about having a referral, primarily from a GP, from primary care, to a link worker, and the link worker would you know, essentially welcome the individual, this person who has a need. We can talk about the needs later, but essentially talk to that person over one session, 2 sessions, or more, and try to establish what the problems are in more detail, and co-produce some sort of action plan, which then helps the link worker to refer that individual onto the voluntary sector for that activity. So it might be, as I said, yoga, it might be anything. And crucially, actually, it's not just about health, but it's also about social issues. So about 20% of GP consultations have some sort of social problem at their basis. So it might be unemployment, it might be housing, it might be debt, And so the social prescribing helps people with their health, but also trying to address some sort of the social determinants of health too, which might be, again, housing and employment. So the picture is varied, and also over time, although, say, for example, in 2015, there was this more, so it's made of three parts. So there's the GP, referring the individual to the link worker, and then the onward referral to the voluntary sector. But over time, he has developed in something a bit more of a monster.
Like, a good one, though.
A good one, yes. Because of the popularity of the idea, local authorities have started referring people into social prescribing too, not just the GP, but also the local authorities. And there are also examples of secondary care, so hospitals, for example, especially actually during the pandemic. There are many schemes, or many, I mean, there are schemes starting with people who are who come out from hospital, from COVID, and are helped with being referred to the voluntary sector again, so that they can help with that. So that's but the picture is mixed because it depends where in the country, depends on what also what target population we're talking about. So in some areas, for example, Redbridge has a social prescribing schemes that kind of targets people who are socially isolated or lonely, primarily. So that's their target group, and there are other areas who target frequent attenders to primary care, like Hackney, for example, used to, and now has widened their reach even. So frequent attenders to primary care are their where their target group, and so on. It can go on and on. It is quite big.
So I mean, there's quite a limit to the number of link workers through the connector program with the NHS. I think there's only about just under 1,500 link workers, but we have an enormous demand for the services. I mean, the voluntary sector being able to scale that?
Yeah, I mean, yes. So the NHS has a target had a target of 20 over the 2021 period of about 1,000 link workers to be recruited and work in social prescribing, helping with referrals. They call it the connector scheme. They actually exceeded their own target, which is good. As Louise pointed out, it's 1,500. However, the scale of the problem is such that a lot more needs to be done, really. So, for example, the pandemic, there is data on the pandemic and the number of referrals to social prescribing, they increased 4 times over the pandemic. And this is data from the Social Prescribing Observatory, which is run by Oxford University, and is quite good source of information actually on this. So that's one thing. And also there is data from the King's Fund, for example. A few years back, they estimated that there are about 50 million people in England with long-term conditions. And so basically the scale of the problem is such that 1,500 link workers are a lot less than what is needed, essentially. But it's going the right direction. I don't want to have to be critical towards the NHS because it's going the right direction, to be honest.
And I guess for us, as an institute, we want to explore what we can do to support that. But it seems like the link workers need to have quite a broad set of skills. So to be able to, if we were to build out the infrastructure and the availability, perhaps, of the activities that could be prescribed, because at the moment you've got all this silo happening, and you've got multiple people searching similar things and finding it in different places or in bits of paper or whatever it might be. I mean, my own experience of going to the GP recently was, I suffer with a sore back, and it's like, oh, here's a piece of paper. Right, so there's a place down the road you can do a Pilates class, so that was the intervention. you're not getting the pills. Probably not a bad thing. But it's quite sort of paper, manual, disjointed. But the link worker needs to be able to have knowledge to access all of that. So if the infrastructure was more digital, is there a skills gap there, do you think, for those link workers?
Yeah, I mean, definitely. I mean, just in if you take Hackney, for example, or Redbridge, there are different. Now it's more unified, but there were a few years ago, for example, there were many different databases of activities, and it's about integrating all of that. It's about making sure that link workers can access all that information that then they can use to refer individuals. Is also about obviously what the individual wants, what the location. So most people can't really travel too far away from where they live to attend activities. So because actually these people we're talking about are people who might be have mental health problems, physical problems, and so they might find it difficult to move far away to attend activities. So it's all of that. So the geography and so on.
Accessibility.
Yeah, exactly. Accessibility, exactly. So and one I mean one of the issues there that is how to get to collect all that information and really is not just about the information that might be available, but is also how to look at how we can get people to attend those activities and study all of that. And all of that is not possible if you're not collecting the data in the first place. So that's yeah.
So, I mean, we have a program of work here at the ODI that we've worked on for the last 5 years, which is called Open Active, and that's supported by Sport England. And that's actually looking at publishing activity data. But I think one of the things that we've certainly learned as we've gone through the program is that when you're making seismic shifts to sectors, it takes a long time. It does take a long time. But you know, you just have to stick with it, and you've got to have that commitment of funding. I mean, what we're looking to explore is, you know, we've built booking APIs. We've booked, you know, we have accessibility standards attached to the activity standards that have been produced, and we think that there's potentially an opportunity to extend that out beyond physical activity. So to use an infrastructure that exists in order to try and standardize this data, make sure that we address all the accessibility issues, etc., and you know, make it easy for the link worker to find the opportunity to be able to sort of refer the individual onto. At the moment, I mean, how are they actually finding the activities? I mean, is it literally a Google or a bit of a database somewhere?
Well, it varies very much according to the place. So, as I said earlier, I mean, Hackney, for example, now has one centralized system where people can go and look for activities. The main issue really is who pays for the database to be updated, and whether the activities, you know, because of the nature of the voluntary sector might provide an activity today, but in 3 months' time might not provide that activity anymore because there are limitations on the funding available. And so that's updating regularly the database that one uses to access this activity is key. Because otherwise one might select yoga and the yoga class isn't there any longer because the funding is not available. And unfortunately, the voluntary sector has limited funding, received limited funding, has been throughout austerity. I mean, there is evidence about this. If you talk about social prescribing, every time you go to the social prescribing event, the issue of funding is raised. Having said that, I mean, of course, it is important to produce the data, but is, as I said, important to update the data and keep it regularly monitored. And that's something that the link workers normally do. So if the link worker is a good link worker, they normally have relationship with the voluntary sector in their patch. So, for example, in Hackney, there are now probably 7-8 link workers. And they spread, they have several areas of Hackney. They control an area, or they control. I mean, they provide support in an area, and so they know what voluntary sector activities are available in that particular area, and that's why that's one of the key rationales to have a link worker in the first place. And the other, of course, I'm moving on to the link worker now, but it's worth to point that out. So the link workers really essentially builds a relationship with that individual. It's not just about kind of signposting the guy. So John wants yoga classes. Okay, John, there's yoga classes down there, or go there. It's not just about that. It's about listening to what John says, and kind of in a lot of detail, and then move on to kind of look at what activities that John might need. And of course, John has a voice in the whole process. That's key too, because otherwise John will not go to the activity, and then we're wasting money here.
And what about the Johns that don't have a GP that refers them to a link worker, or a child that doesn't sort of get referred through that route?
Yeah, good point. I mean, nowadays, social prescribing has become more and more about self-referral. So one can self-refer into social prescribing, and the adult most adults go to see their GP, and so they can be referred through that through the pathway. When it comes to young people, it's a bit more difficult because young people don't. Evidence shows that not many young people go to see the GP in the first place. So you got a problem there in terms of the social prescribing pathway, which relies on the GP. And so the social prescribing scheme need to kind of be designed in a way that they work more with schools rather than GP practices, or with GP practice and schools and other sources. For example, there are models that use CAMS, children and the mental health services, and they get referrals from CAMS and then they refer people into social prescribing. So it needs to be looked more, what kind of referral source, referral routes there are. So I was, for example, I've led an evaluation of social prescribing across 4 English sites. One is Sheffield, Luton, Brighton, and Southampton. Over a 2 years evaluation with street games. We worked together to produce the evaluation, and there were organizations in these 4 areas delivering social prescribing. And in Sheffield, for example, Sheffield has cafes across Sheffield, has few cafes, and the cafes basically are for young people, so sort of youth centers, sort of. And young people can go there, and then they get referred through that means. So there are different ways of doing it. So yeah.
So do you think, therefore, it's useful to sort of expand the capture of activities? So I'm trying to explain that a bit better. So, for example, you might have young people go to the Scouts. But that might necessarily be seen as a social prescribed activity in sort of the referral GP link worker sense. So there's lots of local initiatives, whether it's the drop-in cafe or the afternoon tea, that could actually be very beneficial to our well-being as a society, without us needing to kind of go through the route of the GP, the link worker, because actually I just want to interact with an activity because I'm feeling a bit blue today, and it would be nice to sort of spend some time with other people. So really expanding that out. I mean, do you see a purpose for that?
Yeah, I mean, the wider the net and the more activities are provided, and people know, the more people know, and the link workers in particular, or even individuals know about those activities, and the better. I mean, at the end of the day, there's a lot of, it's fairly evidence that participation is good for your health and well-being in general, and there is lots of evidence on yoga, peer support, arts. There is stuff done by UCL, for example, on arts. There is stuff on green prescription, how good it is to go out in the wild, in the woods and in parks and so on. So participation to those activities is good for you because it's good in terms of your mental health, and the kind of a mechanism is really the social connection that is at the basis of all these activities. The more one is socially connected, and the better is for their mental health and well-being, essentially. And they create networks of support with some people over time, and so that's again a more long-term, potential for people's health and well-being improvements.
So when you look at John, that's gone on to, talk to the link worker, good old John, and he's decided that he's going to, interact with a yoga activity. So how does the link worker know whether that's worked for John? How do we capture success or impact?
Okay. The way it has been done in evaluations of social prescribing is that basically, generally, we have they collect two measures, one a baseline, or maybe more than two, but a baseline and maybe a 3 months or 6 months. So you basically the people who go through the social prescribing get their baseline measure. You can ask them about their mental well-being. There are tools, there are measures. I mean, I'm not going to go on that; it's quite long. But there are tools and measures to measure mental well-being, for example. And then you measure that after 3 months or 6 months, so you know whether that person has improved their mental well-being. So that's one way of doing it, but is not the most accurate way, because actually you don't know how many times you know that the mental well-being of that person might have improved, but you don't know how many times John has gone to the yoga classes, and the link worker doesn't have that information, generally speaking. The information might be with the yoga class and the person running the yoga class. And unfortunately, the problem there is that in most cases, the person running the yoga class will not collect that data. So there needs to be a mechanism that helps that person to collect that data. And unfortunately, they don't do it for a variety of reasons. One being that they don't have an incentive, essentially, to collect that data. They're not funded by the scheme to collect that data. They might do it, but it's always kind of patchy.
So it makes it really difficult then. I mean, if you're trying to unlock funding, we know that an intervention like this is a long haul, but the benefits would be significant based on some of the evidence that we've got. In order to demonstrate the societal impact in a positive way, if you don't get the feedback on John, how else do we measure it to justify the investment?
Is normally measured on the improvement in mental well-being or whatever. The example I was just making earlier about the mental well-being. So if somebody improves their mental well-being, the impact, the mental well-being can be transformed into some sort of financial value, and there are different methodology approaches to do that. So these are called social return on investment studies, for example, and there've been a fair few social return on investment studies being done on social prescribing overall, and these is a form of economic evaluation, basically. is a cost-benefit analysis, to be precise. I mean, and these overall they proved positive value. And also what happens is that but there are lots of little problems which we can go into. But the other point that is important is, as we discussed earlier, is that whether individuals like John, for example, go to see their GP less, so have fewer GP consultations as a result of social prescribing, and generally speaking. Yes, that's the case. So there's been a systematic review. Well, systematic review on this, which showed declining GP consultations, but more needs to be done there, because often the studies we looked at have small sample sizes. The time scale might be reduced, and often they don't have a comparison group. Not all. There's few small studies that have a comparison group. I don't know, maybe I'm going too much into the depth here, but yeah, the use of control groups is quite important.
Because I was interested, and I think you were involved in this study, the 2017 study. The University of Westminster had an evidence summary at that point. And, you know, it sometimes everything seems to point to positive outcome, positive impact. And this study identified 28% fewer GP consultations and 24 fewer A&E attendance for people that were receiving the social prescribing support. I mean, was there anything else that was interesting in that report?
Yeah, I mean, that basically collected a variety of evaluations from different studies, and basically we took some sort of an average of that. I mean, one of the things that is interesting is that really even within the group of people who are referred to social prescribing, even who are normally people with certain needs, quite high needs, and they are often quite high demand you know, they might go to the GP a lot, basically. Even within that group, there is a smaller group, a subgroup, which actually goes to the GP a lot. I mean, significantly more than the others. So what it tends to push up or down the GP consultation rate. So and is that really the small subgroup that needs that creates the number of consultation rates, and also can be part of the solution. So if we kind of help those people who are very high needs and go a really high frequent attenders to GP practice, they're called. If we help those more, then we will really help the whole system much more as well. And the case, excuse me, and the case can be made more strongly to NHS to invest as well. If one goes to see a link worker, then there is the flexibility, because the link worker can then use, well, they can use the social media, databases and electronic databases and data to find the right activity, and one who's doesn't use the computer or can then be referred anyway. And benefit from it anyway, yeah. Although the kind of social prescribing started, maybe the actual term social prescribing started, say, 2015, 2014, kind of to be well known. It really caught up in the NHS at the beginning of 2019. And actually, they made link workers available to run social prescribing scheme in GP practices only starting in July 2019. So we are talking about 2 years ago. Am I going? Yeah, about 2 years ago. And this stuff takes time. There are loads of issues with some GP likes it, some GP don't. So it takes time for GP to trust the system, to trust referring a person, and GP practices as a whole might be more or less inclined to kind of refer people. But normally, in our experience, it takes time because it takes trust, it takes building trust and it takes the link worker going into GP practices regularly to try to convince GPs and kind of encourage them that way.
And of course, there's a limit to the number of link workers right now. We've got 1,500
yeah. So the link workers does few beats, isn't it? So
yeah.
he tries to convince on the GP to refer. He keeps links with the voluntary sector, and of course, he has to help the individual. So there are loads of issues, but yeah. In answer to your question, he's kind of patchy, but he's catching up. And technically speaking, social prescribing is now available nationally, so one should be able to access it anywhere. Well, you can demand the GP to refer you, and sometimes even the nurse in a GP practice. If they don't, it really does vary on the geography, and where you live, essentially. Access depends very much because in some social prescribing scheme include self-referral, so there is a way to self-refer into the system without the GP being involved, and so it's very varied. I mean, and I don't know all the geography across it would be difficult. One of the points you're raising here is, say, for example, again, let's talk about John again. John lives at the edge of, say, Hackney, and he wants, but he has a service just in the adjacent borough, but he doesn't know about it because that patch is linked to the database for, say, I don't know, Newham or whatever, or Tower Hamlets or whatever. So the reason, I'm afraid, there isn't a solution. I mean, there are lots of people that are trying to find a solution, and it needs to be found. But certainly there isn't a solution. I mean, there is a private sector like Elemental Software, which is a company. A company that looks at the whole pathway of social prescribing from the GP all the way to the voluntary sector, and they provide some support with that aspect, and they have basically a platform which can be accessed by the GP, by the link worker, by the user, and by the voluntary sector, and they collect the information that way. But it doesn't solve the problem either. I mean, it solves partially the problem because they also take on information, and but is specific to a social prescribing scheme. Is not open data, but even open data needs to kind of make sure that the data is updated in some ways, because as I said earlier, there are limitations on the funding available to the voluntary sector. So the yoga class might be here today, but gone tomorrow, and that's the real problem. I mean, one can think about it is talked about a lot about you want to go on holiday, and you go to the estate agent, to the travel agent, to the travel agent, and the travel agent would be the link worker, but if there are no places to go, you're stuck. So I don't know. I didn't make this example very good, but anyway, the point is that there's no enough supply of activities, and because of the limitation on funding. I mean, the funding from local authority is one of the major moving away maybe from this, but local authority is one of the major funding of voluntary sector activities and voluntary sector, and they during the period of austerity they saw from the last 10 years, from 2010 to 2019 I think it is, they saw 38% cuts in their funding. So it's likely that much of that goes to cutting funding to the voluntary sector. So if you want to have a good social prescribing, you need a better voluntary sector funding, really.